So Rajagopal sir will be talking to you about how to take care of a difficult pain patient, and uh, I think he doesn't need any introduction because he has already taken sessions for you. Welcome, sir, and it's over to you.
Thank you, Sunil. Raju, just one clarification. How many sessions have I done for this group?
3 sessions, sir.
Okay. So good to see you again, friends. I think the faculty is coming with various adornments. I have a small bandage here, nothing serious. Sunil is wearing a collar. So that's not, it may appear to be a very unhappy situation, but we are all okay. So we're good to be with you again. So as Sunil said, you have gone through so many sessions, several on pain. You have seen the ladder. You have had detailed discussions about non-steroidal anti-inflammatory drugs, opioids, adjuvants, etc. So if we use all that, if we use the ladder, WHO analgesic ladder, as it is, what percentage of cancer pains can we treat effectively? Effectively means with pain relief to the patient's satisfaction. You don't usually aim to achieve complete control over pain. What you aim to achieve is something that is satisfactory pain relief for the patient. And what percentage do you think will be possible? 100%? Can we treat with the ladder? Can we treat every cancer pain effectively? Take a guess. Oh, Sabita Binu, Biji Nanda. Sabita Binu says 75%. Biji says 60 to 70. Vandana Khan says 70%. Well, the little, okay, I think I would, Raju, may I share the screen?
Sure, sir.
So, with the simple application of the ladder, the evidence that we have already shows that only about 75% can be effectively treated. I'll show you the evidence. So for all the others, we need more strategizing. What else can we do to the approximately 25% of patients who do not get adequate pain relief with the ladder? And to illustrate that issue, let us see this patient story. She complains of pain all over her body, worse in the areas of bony metastasis. She has had diclofenac and developed gastritis. She was unable to sleep and came to us pleading, please kill me. I can't bear to see this. So naturally you take out your ladder and put it on her, right? Well, she had already been on the ladder, as it turned out. The diclofenac had been withdrawn and the patient had been put on morphine and a laxative. The pain relief, there was some relief, but not anywhere near to her satisfaction at all. So the palliative care physician increased the dose to 15 milligrams 4 hourly. But the patient is not happy. You ask, I mean, the family says her pain relief is a bit better. But she says, I don't want this, I don't want this. What do you think is happening here? Will you gently persuade her to continue the same medicine? Is there any other question that you will ask her? Any chat response?
Sir, Dr. Sandeep has said counseling, sir. Dr. Sandeep have mentioned counseling.
Counseling is a very vague term. Okay, suppose her name is Charida, so I say Charida. See, if you are to get pain relief, you have to take the tablets on time. You see, otherwise you will not get pain relief. Please take the tablet. Hey, Sandeep, how about that?
So, counseling, like I would like to undergo and ask or inquire what are reasons to find out underlying psychological issue also disturbing her. Whereas one part, the family is still saying they appears the patient is better, but patient is not still convinced. So I try to explore underlying issues if I could able to address it. So that could.
Isn't that great? Counseling really involves more listening than talking. Just giving her speeches will not help. We have to find out what exactly is happening. Why does this lady, fall under the 25% of people approximately, 25 to 29%, 24 to 29% according to these two studies, where the analgesic ladder was not giving the person satisfactory pain relief.
Sir,
The
there are
first,
some more comments like gabapentin, anxiolytics, reassess pain, etc.
okay, I mean, why is it that I am unable to see the chats? Is it because, let me see. What am I doing wrong? Anyway, Sunil or Raju, one of you, will you please read out the chat messages one by one?
So, why does she not want it? Then reasons to find more underlying issues. Another response, gabapentin, anxiolytics. Another, reassess pain.
Okay, now I can see, I managed it.
Yeah.
Okay,
Okay.
why does she want the medicine? This is what Sandeep also said. Look, what's the problem? And why does she want it? What are the underlying issues? You need to find out more. It is not, I mean, straight away prescribing gabapentin or anxiolytic is too knee-jerk reaction. Wait, there may be a role for more medicines, but wait. Okay, so the first point that we must remember is that very often when we are unable to treat pain effectively, we may have a tendency to put the blame on the patient. She must be all imagining it. How can she not have pain relief? Actually, I've actually seen once where a patient was having crying out aloud with postoperative pain. And the nurse was asking, how can you have pain? You have an epidural in. Now, the first step, we start by believing the patient about the pain. Then, could the patient be having a pain that is not opioid sensitive? Could there be one criticism against palliative care physicians very often is that we cause failure of treatment because we keep on giving analgesics and do not give the corrective measures. Of course, if this patient has bony mets, for patient with bony mets, radiation, one single fraction palliative radiation is the best form of treatment. Most effective, more than anything else. Not 100%, but close to 70 to 80% relief. 70 to 80% patients will have good relief for a significant length of time, maybe months together. Sometimes, say in CA ovary, chemotherapy may be the best way. And if there is an intestinal obstruction, maybe ostomy may be the best answer. So let us imagine, let us think, am I being so much of a palliative care physician that I am forgetting the rest of medicine? Look for correctable factors. And this is very important. make sure that we check whether the person is really adhering to your schedule. Okay, you have written paracetamol 6 hourly, morphine 4 hourly. The patient may not have understood, or very often somebody may tell them, hey, don't, this can be too much. The most likely thing is another doctor or a nurse, what, 4 hourly? Hey, take it only 3 times a day. And they will do that if the other person is a trusted person. So checking adherence is very important, and affordability is another issue. In the case of affordability, let me give you these comparative figures. These are the average prices of 10 milligrams of morphine for a day, cost per day. See, very often we are quick to prescribe transdermal fentanyl. We don't give a second thought to it. See how expensive that is. Okay. So affordability also can be a problem, which results in poor adherence to patient treatment, but very often it's fear of tablets or side effects. And just one more sentence. I know so many of you have said the correct thing. If the person is not taking the medicines properly, never start the address the issue by asking, why don't you take the medicines properly? Instead, I would say, if you are not taking the morphine 4 hourly, there must be a good reason. Tell me what that is. Is it giving you a side effect? Or are you scared about some side effect or some problem? And when you put it that way, if you are not sounding threatening, they are so much more likely to confide in you. So I have already mentioned 3 steps. The first step is to believe the patient about the pain. The second step is to correct correctable factors. The third step is to check adherence to treatment. Going on to fourth, somebody already said this in the chat option. Yes, maybe the person has a serious anxiety disorder or a depressive illness. Depression and advanced cancer can have as much of an incidence as 1/3 of all. This is a problem. So we have to look into it. If the patient is depressed and therefore feels the pain more, remember, pain is a sensory and emotional experience. It doesn't mean that the patient is pretending. So if the person is having anxiety, find out what the anxiety is about. Depression, is it really the sadness proportionate to the situation, or is it a depressive illness? What does the patient understand about the diagnosis and prognosis? What are the person's fears? People are afraid of so many different things. Don't make assumptions. They may not be afraid of death. They may be afraid of the dying process. So many possibilities are there. So looking for psychological and social issues which makes the pain experience worse is another important step. So that was our step 4. Okay. And some of you mentioned this already. Review the medication for the dose, the frequency, the choice of medicine, everything. For example, the person is getting paracetamol TID. Is paracetamol of any use in cancer pain? Yes, it can be useful. It can be useful because it may lay a foundation on which you can build the rest of the treatment. But is the frequency 650 milligrams is the right dose? Suppose she is around 50 kg. Well, yes, about 12 milligram per kg is a reasonable dose. Anything less than that is not those who take paracetamol for a headache or for something else, please remember, think of your body weight. What would be the right dose for you? If you are 60 kg and you are swallowing a 500 milligram tablet, clearly that's inadequate. But as Dr. Sandeep said, paracetamol does not act for more than 6 hours. 4 to 6 hours is the optimal duration of action. So paracetamol is ordinarily given at least 4 times a day. Morphine, 4 hourly, that sounds good. Bisacodyl sounds good. So we review the regime, and then we reconsider the adjuvant measures. What kind of pain does she have? If it is bony pain, okay, we know she had a problem with diclofenac. Maybe at that time she did not have gastroprotection. Because particularly in bony pain, it can be very hard. Controlling the inflammatory products which cause pressure inside the pain and cause bone and cause pain, that can be an effective way of treating it. So we might reconsider that, or we might consider adjuvant measures. Now earlier in the chat, one of you mentioned pregabalin, and I particularly point out the cost factor. Listen,
Sir,
the major,
there is a chat question. What is the difference between breakthrough pain and end of dose pain?
Sunil, will you please help me make a note of that question? Let me come back to that at the end.
Okay.
Okay, during discussion. There may be other questions also. It will be a big help if you'll take a note of the questions, including that accessibility issue. So I will repeat, the most expensive is not necessarily the best. And expensive treatment, I've seen so many times when they take all these medicines, sometimes multivitamin mineral prescriptions. Listen, for somebody with advanced cancer, what good will that multivitamin mineral preparation do? When the bone marrow cannot make red cells because it's advanced cancer, what good will an iron and folic acid supplementation do? Let us just, if all of us take a pledge to avoid even a single unnecessary medicine, a lot of improvement will happen in the social situation. So this is one of the things, and especially in neuropathic pain, please remember this. According to guidelines available globally, gabapentin or pregabalin are not first-line medicines. There are some guidelines which give this, but we'll talk more about it. All neuropathic pains are not the same. If it's a trigeminal neuralgia, you will start with an anticonvulsant, and that may be carbamazepine or sodium valproate. In diabetic neuropathy, very often duloxetine is used as a first-line medicine. And otherwise, in cancer neuropathic pain, amitriptyline, judiciously started and judiciously increased, will be the medicine of choice. And particularly about gabapentin and pregabalin, gabapentinoids. These guidelines published in 2019. 2017 already it was rejected from the WHO model list of essential medicines. They refused to include it, and I would encourage you to look at this guideline of 2019 on cancer pain. Raju, I suppose you will be sending this presentation to all of them. And 2019, after a lot of evidence, they actually say gabapentin and gabapentinoids, pregabalin is a gabapentinoid, are not included because fraudulent evidence was submitted and thereby guidelines were made earlier. And they actually have given 5 references there. 5 different references about fraudulent evidence created and submitted to the world. So let us not assume that the most expensive is the best. I'm not saying that gabapentinoids have no role. I'm just saying that they are clearly not the first line drugs and they are expensive. One of the adjuvants in some kinds of pain, particularly we are talking about neuropathic pain now, not about the lady's bone pain. Lignocaine infusion given over a few hours and if beneficial, continued as an infusion for 5 days may be helpful. And if that is found to be effective, switching over to overflecainide may be a good option. But remember, these are medicines with significant side effects and particularly to be avoided in any patient with a bradyarrhythmia. So, I mean, apart from the usual adjuvants that you use in neuropathic pain, in addition to the routine first line of amitriptyline, etc., we may consider other adjuvants. Okay, listen, everything that we said so far was nothing unusual. We were all talking up to this point, we were talking about very usually used medicines, and only this is a bit unusual, very familiar to cardiologists and anesthetists, but may not be so familiar to others. Now we are going into a little after 5 steps are over. Step 6 to 10 are about other medication or procedures that we may consider. The first thing that we'll talk about is opioid switch. Patients who do not tolerate oral morphine may tolerate other step 3 opioids. It doesn't make sense to switch over from morphine to tramadol, but switch over to another step 3 opioids. What are the step 3 opioids available in our country other than injectables?
Anybody?
The transdermal fentanyl and oral and injectable methadone. These are the only choices. Methadone, Sunil, at the moment it's only oral available, right?
Yes, sir.
Injection has been discontinued. So oral methadone is inexpensive. The rules governing methadone administration are the same as access to methadone are the same as morphine. So there's no reason why you cannot get methadone. The only catch is it is a medicine with a narrower side effect profile. In low doses, it's hardly harmful, but as your dose increases, one has to be careful. You have to understand the medicine to use it properly. But mark it in your diary as something that you have to learn about how to use methadone, because out of the 25% who do not respond to the ladder normally, a good number may respond to methadone. We may talk more about the opioids, but another step that we have to try is, hey, is any intervention possible? Maybe not in this case with multiple bony mets, but if it was a pancreatic pain, maybe a celiac plexus block may be a very good way of achieving pain relief, and so on. So if it is a lower abdominal lesion and pain, it is not so easily treated, but we may be able to put in an epidural catheter and take care of several pains. And let us not underestimate non-pharmacological measures. Some people do respond well in some kinds of pain, at least to non-pharmacological measures like transcutaneous electrical nerve stimulation. So if your institution has a interventional pain management division, you may consider a referral. Here's a question for you. When the dose of morphine is increased from 10 to 15, the person is getting delirious and drowsy. Will it be easier to manage this person with a parenteral medication? Let us take a minute to understand how morphine gets metabolized. You don't have to necessarily remember everything, but morphine 3-glucuronide, morphine 6-glucuronide, normorphine, and several other chemicals are metabolites of morphine. Now, our understanding is still confused as it was quarter of a century back, but we believe that morphine 6-glucuronide has a significant analgesic action. When you give morphine and patient gets pain relief, the pain relief is caused both by the morphine molecule and by the morphine 6-glucuronide molecule. Another glucuronide, morphine 3-glucuronide, which is again made in the liver, is suspected to be the reason for many side effects with morphine. Now, this is one of the reasons why opioid switch also works. When the patient gets delirious with higher dose of morphine, you switch over to methadone, and that's tolerated partly, at least, because of this. But here consider, these are metabolites that are products of metabolism of morphine in the liver. Okay, so suppose at least partly you are bypassing the liver by giving the medicine parenterally, not through the stomach, not so much going into the liver intravenously or subcutaneously. Don't you think there is likely to be less of glucuronides in the system? This is the principle which behind some, not a small number, significant number of patients who do not tolerate oral morphine, tolerate parenteral morphine. So numerous times Sunil has treated patients like this. They simply do not tolerate the morphine when it's increased to 20 or 30 milligrams, but they seem to be comfortable on an infusion, subcutaneous infusion of morphine, or even 4-hourly injection, subcutaneous morphine. Okay. So bear this in mind. If the patient can be hospitalized, maybe this can be done. But repeatedly, several times I have done this. When the patient cannot be admitted, they are simply not able to come to the hospital institution. They can stay at home. I have numerous times given them an injection filled with diluted morphine, a syringe filled with diluted morphine. A butterfly needle is in position. The syringe is fixed to that and attached to the body. A family member every 4 hours pushes 1 ml of the medicine. Your dilution of the morphine should be such that 1 ml will be 1 dose. So after 2 days, the family member comes back, brings the old syringe, takes a new syringe. We don't give out ampules because of the potential of abuse, but we give pre-filled syringes, diluted morphine. Is it legal? Well, there is nothing illegal about it because nowhere in the law it is said that it cannot be done. And actually, Indian Association of Palliative Care has a guideline given, a position statement published on its website, which says that patients' families can and should give medicines by the subcutaneous route when necessary. After all, insulin is a potentially lethal medicine, isn't it? But you allow patients and families to inject it. Similarly, this also is permissible. Now, some patients genetically make more M3 glucuronide, maybe about 15 to 20% of people. And particularly for them, tolerance to morphine may be poor, and therefore this parenteral may be a good option when feasible. If the patient cannot get admitted and is coming from 100 kilometers away, understandably this will be difficult. Any question about this? You can ask this by chat. Okay. Remember, when we talked about the pathophysiology of pain, we must have talked about central sensitization. On the one end, you have peripheral nerve. This is a peripheral nerve which responds to the nociceptor by generation of electrical impulses, which pass through the peripheral nerve to the dorsal horn of the spinal cord, where the impulse gets modified. Then it crosses to the opposite side and goes to the brain. With a continuous barrage of impulses, numerous impulses continuously going and not stopping a day after day, the dorsal horn cell really gets abnormal. The process is called sensitization or wind up, like winding up a spring so that it's so tight that you press it and it goes. This phenomenon is called central sensitization or wind up. The result is, once the dorsal horn cell has become abnormal, one impulse going from here tomorrow will cause 10 impulses to go up to the brain. Day after tomorrow, 200 impulses. The pain impulses in quantity also will be increased. In addition, there is an anatomical disruption of the structure of the dorsal horn. If you remember your physiology, though not anatomically, functionally, the dorsal horn cells are arranged in laminae, superficial to deep. This laminar structure gets lost so that even touch gets perceived as pain. So this central sensitization will have to be treated. NMDA, N-methyl D-aspartate. You don't have to remember that, but anesthetists must be familiar with this. N-methyl D-aspartate is the neurotransmitter which is believed to be most responsible for central sensitization. So it is also hypothesized that if you block NMDA, you treat central sensitization. That is, if you block NMDA, you are giving the dorsal horn time to recover, and after that, the patient may respond to the regime much better. So, who wants to tell me NMDA antagonist? The anesthetic agent ketamine acts by NMDA blockade. Sandeep, I saw your question. We'll come back to that. Thank you for so many people who mentioned ketamine. So what we could try is ketamine burst therapy. That's a dose. 100 milligrams in 24 hours, 100 to 500 milligrams in 24 hours. This is what you would dose as a single dose for inducing anesthesia, right? The same dose in sub-anesthetic concentration given over a 24-hour period as an infusion. It can be intravenous also. Is used for the so-called ketamine burst therapy. And typically 3 to 5 days of ketamine burst therapy is given. By that time, hopefully, this has subsided to a small extent. Rarely, we may continue for longer periods of time. Hopefully, after 3 to 5 days, the patient will be responding to your morphine and other medicines much better. This Michael Cousins is a big name in pain medicine, who is author of several books, including Neural Blockade. And that's a recommendation from them. Now, suppose the patient cannot get admitted. Patient will stay at home. Maybe we can give oral ketamine. Actually, there is a view that oral ketamine is even more potent and longer acting because it generates more of norketamine. Now, this is a question that Sandeep raised in the context of injection also. If you give parenterally, is the liver bypassed? Not completely, but imagine what happens. You take it orally. The whole of the absorbed medicine passes through the liver, right? Whereas if it is parenteral, only a proportion of the medicine going through the systemic circulation will get to the brain. There is some metabolism occurring in the liver anyway, even if you give it parenterally. But with orally, that initial absorption is so much more. This is why both in the case of morphine, we believe that the production of M3G will be less. M6G also will be less, but then morphine molecules will be working more. And similarly, if you give it orally, all the ketamine will be absorbed from the stomach, and there will be a larger concentration of norketamine produced in the blood, and therefore it can be quite efficient. The dose used is small. This means for a 50 kg person, it's only about 10 milligram. For a 50 kg person, 10 to 25 milligram per kg, 3 to 4 times a day. We have only injectable ketamine in our country, as far as I know. And therefore, we will have to give it. We will have to draw out the injectable medicine in the right dose, mix it with a sweetened drink because it can be bitter, and administered orally. It can cause emesis, so it is judicious to give an antiemetic. Significant histamine release occurs in some people. I have seen people getting oral ulcerations. These are some of the potential disadvantages. So where were we? We were at step 9. Treating central sensitization and then continuing the ladder. So it is generally accepted that this is certainly not for everybody. Not only in cancer pain, other chronic pain patients also, there it may be worth a trial. But to important side effects you will have to remember. One, what has been seen more and more in the last 15 years is ketamine-induced hepatic damage. This is not pure theory. After seeing these reports, we started monitoring people's SGPT when we start ketamine. And we found that in a good number of patients, yes, SGPT does rise. And if we find a significant rise in SGPT, we stop the ketamine therapy there. And another side effect, which also we should be very cautious about, is the vesicopathy. This appears to be a chemical vesicopathy. It manifests like any cystitis. So one of the things that we always do after, again, only in the last 15 years, we did not know that earlier. The patient, after starting ketamine, you ask every day, by any chance, do you have any burning micturition? And if they say yes, you stop ketamine, because it has been found that unfortunately, if you continue it, even after you stop ketamine therapy, the cystitis-like symptoms will persist. So remember hepatotoxicity and vesicopathy. So the 9 steps that we have so far mentioned, I see that there are several chat comments and questions. We'll run through them during the discussion time. Oh, I see that we are doing reasonably okay with time. The first step, believe the patient about the pain. Look for correctable factors and correct them. Check adherence to treatment, and somebody added adherence, not only affordability but also accessibility. Yes, if the medicine is if you just prescribe it, the medicine is not available, how will they get pain relief? Look for emotional overlay, anxiety, depression, etc. Review the analgesic regime. Have we given the right doses at the right intervals? Are we using the right adjuvants? Is there something else we can do? And consider opioid switch. Switch over to methadone if possible. Even after the course, do please feel free to write to us. Sunil has much more experience with methadone than myself, and we certainly will be very happy to give you guidance. Review the role of interventions. Are we forgetting something? Interventions and non-pharmacological measures. Consider an alternate route to the analgesic, like subcutaneous or parenteral or even epidural. Consider ketamine to treat central sensitization. And then I'll end with the step 10. By the way, this is not like WHO ladder, not an internationally approved protocol or anything. Something that I practice to try in an effort to be systematic, and several times we have moved the position of each step. So what do? Very unfortunately, doctors, after everything that we do, a small proportion of patients will still not get satisfactory pain relief. This percentage can be 5 to 10% in cancer, even with these procedures. If it is a terminally ill cancer patient, we can consider palliative sedation. Sunil will always remember Sudhakaran, so will I. Some patients, when we are sure that they are terminally ill, if they continue to be in agonizing pain, that's horrendous. We would just consider them deep enough sedation so that they don't feel the pain anymore. Maybe it will be good to look up palliative sedation and learn about it a little bit. That is certainly not for a beginner. If you come across that, by certainly contact one of us, consult Sunil or I or somebody and get guidance about this. But suppose it's not a terminal illness. It can be any chronic pain. Then what do? There, just like the patient has to be in acceptance about the diagnosis and prognosis, the patient and we need to be in acceptance about our failure. Remember, very often when we fail to achieve something, we may have a tendency to put the blame on the patient. Or sometimes it happens subconsciously. You may, when the patient is walking from there, you see, oh, there he comes again. I have done everything and still he keeps complaining of pain. He must be fussy. And you get irritated. And then he comes and says, Dr. Saab, I still have horrendous pain. How many times did you take this tablet? That one I took only 3 times. And then you snap at them. You never follow my instructions. And look, we have to recognize that our own failure, our own helplessness may make us angry. Angry with the failure, which comes out as anger with the patient. I will remember that even when I fail to give pain relief, I should be a fellow traveler with the patient. I will tell them, I know that whatever I have done has given you only a minimal relief. It has not given you satisfactory pain relief. But we are here for you to do whatever we can. Right at the moment, tell me, how can I help you to live with this pain? The patient will be disappointed. But it's important for the patient to come back to you if there's a worsening in the pain. There may be a new pain. There may be something correctable. And even if you are unable to relieve the pain, the patient needs someone to talk to. And therefore, we should not reject them. I accept my responsibility that my job is not only to treat pain, but it is to be a fellow traveler to them in their difficult journey. So, Sunil, I have finished my presentation. I see that we have some 12 minutes left for discussion. What do you suggest? Shall we take the chat questions first?
Yeah, yes, sir. So
So
the first one was regarding accessibility.
yes. Of course. We should ensure accessibility before we prescribe it, no doubt.
And do you want to talk more about accessibility of opioids, or shall I
No,
go to the second?
I think it's fairly obvious. It's our job to make it accessible. Unless if you don't have methadone, don't prescribe it. Yes, I think I'll stop it about the accessibility there.
Okay, what is the difference between breakthrough pain and end of dose pain?
So the breakthrough pain is a word that is rather loosely used. So breakthrough pain is a pain that breaks through a baseline level of pain. Pain control is at a baseline, and every time you get a pain through this, you call it a breakthrough pain. So the end of dose pain can be a breakthrough pain. But that would be a breakthrough pain that's easy to control. Excuse me for a second. That's a breakthrough pain that's easy to control. There are other breakthrough pains like movement-related pain, incidental pains. The patient has pain relief, reasonable pain relief at rest, but the moment he turns to one side, he shouts in pain. That's called an incidental pain. Incidental pain is also a breakthrough pain. What do? You try to avoid that particular movement. If it's caused by a fracture of the humerus, you try to immobilize that. You try to irradiate that part. So a pain that breaks through a certain baseline pain control is a breakthrough pain, and breakthrough pains can be endodose pain, it can be incident pains, it can be movement related pains.
So in connection with the NMDA and diagnostic medication, there were two comments regarding dextromethorphan and nitrous oxide. What's your opinion?
Very good. Deepa, dextromethorphan and nitrous oxide do have NMDA blocking action, but the advantage of dextromethorphan is it is easily available. You go to the medical store, you can buy it easily. Ketamine is a scheduled medicine, not in the same schedule as morphine, still available only through licensed hospitals. So dextromethorphan is available, but it's a weak NMDA blocker. Can it be given? I suppose yes, but I don't think we have. I mean, like about ketamine, I gave you a few steps in evidence. I don't have such evidence to give about dextromethorphan or about nitrous oxide. Of course, it's not practical. Can ketamine burst therapy started IV for first day, admitting patient, and then continued orally at home? Oh yes, by all means. If the patient can come in for a day, the IV doesn't mean that we can easily convert it to an oral equivalent. There would be that time taken still to adjust the right dose. So personally, if you ask me, if it is agonizing pain, I may give an IV initial, but I would rather be more comfortable starting with oral and titrating it up.
So another question is, during ketamine therapy, do we continue morphine or stop?
The morphine, okay, let us take the actual scenario. Like the case that we described. The patient was on 10 milligrams. It was fine, though, like there was no problem, but pain relief was inadequate. We increased to 15 and she was uncomfortable, possibly because she was getting unpleasant dreams. So what do? You continue the 10 milligram. Wherever you have been winning, you continue that. That's important because eventually, after the few days of ketamine therapy, someday you are likely to want to stop it. And then we will need that baseline opioid medication and the ladder to continue the pain management. Once the dorsal horn is desensitized, your ladder continues. So you continue. It's a short answer. About the hallucinations. Well, Sandeep is asking because you give intravenous ketamine for anesthesia. And when the patient wakes up, the patient claims that you have been trying to kill him, or the patient sees a ghost in front of him, or the patient sees a dead ancestor. Hallucinations following ketamine therapy are rather familiar to anesthetists. So what is likely to happen here? Yes, it is possible, but what is more likely to happen with this low-dose ketamine? Initially is a sense of lightheadedness. They will say they won't be able to explain it. Something is odd. I'm not very comfortable. Something is happening to me. that should be the warning sign. You must immediately bring the dose down to the previous level or stop it for a while and restart it at a lower level. So more likely with oral therapy with gradual increase in the dose would be lightheadedness, but yes, hallucination, delirium, and then hallucinations are possible. Can it be given if existing SGPT is raised? I'll try to avoid it. Uh, after all, this is not a measure that is sure to treat pain. So this is also something that may help. So if the liver is already damaged, I would be hesitant to use it. But remember that in metastatic liver disease, unless it's extensive metastasis, SGPT doesn't increase in the early phase. If there are 2 nodules here and there in the liver, SGPT generally continues to be normal. If it is normal, I would give it. 4 minutes more, Sunil. Any questions that anybody has?
So any more questions? Any doubts?
Question.
Yeah, please.
Dr. Kitty.
Please ask. Your voice is breaking.
You can't hear you. We can't hear you. Your voice is breaking.
Can you
No, can't hear you.
please type it in the chat box? Anybody else?
So Sandeep, I have,
Sandeep,
Yeah.
yes, please.
like as you had mentioned, NSRI for diabetic neuropathy is the first choice. Then the second is amitriptyline. So my first part A question is, will all SNRI will be effective? One.
Well,
And the second part is, will SSRI will also be effective in diabetic neuropathy?
Sandeep, thank you. The first part, by the time I have answered the first part, I'm sure I'll forget the second question. Let us see. Duloxetine specifically has been found to be most effective. Unfortunately, diabetic neuropathy and the resultant pain can be a difficult symptom to control, but duloxetine is specifically the antidepressant of choice in diabetic neuropathy. It's not any SNRI. SSRIs are not known to be as effective as our tricyclic antidepressants. You can imagine, why do we use them for pain management? We use them so that their combined action on norepinephrine and dopaminergic receptors causes the pain relief. The inhibition of reuptake causes accumulation of noradrenaline and dopamine in the neurotransmitter, in the synapses. Now, SSRIs are more dopamine specific. They don't act so much on the norepinephrine, whereas for pain management, norepinephrine is important. So the answer very clearly, tricyclics as a whole are much more effective in neuropathic pain than SSRIs. So much so, there may be patients actually being treated with SSRIs for depression, in whom for a neuropathic pain, we may add a low dose tricyclic carefully. A psychiatrist may think that you're mad, so we'll have to ring them up and explain why we are doing it. Ketki, I have a patient with CA lung, hepatic and vertebral metastasis on palliative chemo and radiation, complaining of severe pain all over his body. He has ascites causing abdominal pain, vertebral mets causing bilateral lower limb pain, relieved for a while with morphine and gabapentin. Now he has severe pain again, multiple pains. So, Ketki, we should go through our 9 steps. See what all we can do. Are we treating all the kinds of pain adequately? The abdominal pain, the ascites has to be removed periodically. The time to tap ascites is when the patient says, it is causing me discomfort, which may be every 3 to 4 days. Are the vertebral meds, have they been radiated? A single fraction radiation may be good to relieve the pain. But if it is lower limb pain, it's likely to be a nerve root compression. If it is, maybe that patient will respond very well to an adjuvant, corticosteroid. So I would rather give that patient, after evaluation, treatment for the ascites tapping, palliative radiation if relevant, and maybe if patient can be started on corticosteroids, I think it may help. He has received radiation already. So between these various measures, we should be able to control them. But this is one of those patients in whom, after you have built up your neuropathic pain medicine, which could well be tricyclic, I know he was on gabapentin, gradually build up amitriptyline, but maybe not so effective, we are not sure. But if not, I think this is one patient in whom a transfer from morphine to methadone may help. Remember that methadone has a tricyclic-like action. It's better in neuropathic pain. So Ketki, please be in touch with Sunil or I, and we'll guide you about that phase of tapering over. And if you have our switching over, and if you do not have methadone, let us at least make sure that you get it. Recurrent ascites, yes, we also do have them. And as soon as the patient feels discomfort, it has to be tapped again. There's no other go. I'm sorry I've exceeded time. Raju must be getting very annoyed with me. Ladies and gentlemen, as usual, thank you very much for the active interaction.
So we will move on with patient story, which will be presented by Dr. Shahira. And by the way, Shahira is my classmate.
Where? Trichure?
Yeah, she was my MBBS classmate, and now she's in Singapore.
Hey, I didn't know that we are having an old reunion of old classmates. Okay, very good. Something to be celebrated.
Okay. Hi, sir. Good evening. Good
Hi.
evening, everyone. So I'll pass on with my presentation. So you know that I'm a volunteer in Singapore Red Cross. And the case presentation, patient is 18 years old, male. He's presented with diagnosis having sarcoma left femur with skeletal metastasis. And he has done surgical resection and reconstruction of left femur and post-op radiation for the primary. And then after 1 year, he developed secondaries and chemotherapy was done, now presented with severe pain, squaring psychological factor. Next slide, please. Yeah, so he presented with excruciating pain in the hip and lower back for 5 days, and along with panic attacks occasionally. And he's diagnosed with Ewing sarcoma, left femur, 2 years back. Before that, he was perfectly all right. And he had aggravating pain while playing football in the college. And it was diagnosed with CT and biopsy. And he underwent pre-op neoadjuvant chemotherapy followed by the resection of the diaphysis, left femur, and reconstruction of bone with external beam radiation. And he has done the physical therapy sessions also. And 1 year after the treatment, again, he felt pain in the lower back while playing football. He has already gone back to the college and started his normal life. So again, the CT diagnosed skeletal metastasis in the sacrum. And he had underwent chemotherapy, 8 cycles. But because he developed severe nausea, vomiting, tiredness, and stress, to see the doctor's appointment, the tests, and all these sessions, he stopped the further treatment. Now, because he developed a significant pain, he went again and asked for pain medicines. It was codeine, 30 mg, 6 hourly, and which was later stepped up to oral morphine, 10 mg for 6 hourly because of the ineffective pain relief. And they have referred to the pain clinic for further management. Exactly. So on examination, the patient is distressed and anxious. He is moderately nourished. Pain score is 10/10. Vitals are normal, but there is a tenderness over the left lumbosacral and left thigh. No swelling or allodynia. His hip movements are restricted. Other than that, there is no sensory or motor loss. Systems are normal. He's currently on medication, morphine, 10 mg, 6 hourly, pregabalin, 75 mg HS, Dalcolax, 5 mg HS, Brufen, 400 mg, and or omeprazole, 20 mg once daily. But before presenting, the previous day, he was taking 3 doses PRN, 10 mg morphine because of his pain, breakthrough pain. Next slide, please. So on investigation, hemoglobin is 11% with there is no blood, other significant blood abnormalities. LFT, RFT normal. CT scans pelvis showed secondary lytic sclerotic bone lesions along the sacral, ala, and body of sacrum. CT thorax, there is no metastasis. Now, because of the pain, patient was admitted and he was started on IV infusion, morphine infusion, started with the 1.5 mg hourly, and it was titrated according to the pain scale till there is no pain, that is 0/10, and the dose was 2.5 milligram per hour, and it was later converted to oral morphine after 24 hours, 30 mg 4th hourly, and injection metoclopramide also given along IV. Then along with that, psychological evaluation was done with cognitive behavioral approaches like breathing exercise, yoga, meditation, music therapy, all these things which elevate his mood was discussed with the patient and the family as further steps, and was advised to attend these sessions, psychological cognitive behavioral therapy sessions. Next slide, please. And psychosocial aspects, patient was very active in sports and athletics in his college. He was he had dreams of getting into admission to his favorable university on sports scholarship, but he dropped out because of this recurrent illness, and he's anxious about the patient parents because he's the only son and his parents are elderly. His father is a retired bank employee and mother is hypertensive, and because of this he became socially detached and he spent the time in his room with his mobile. He observes over his diagnosis and the outcome, how he will be dealing with these things, and he get anxious more often. And after the diagnosis, my parents are also totally distraught. Next slide, please. So the medications is oral morphine 30 mg 4th hourly with PRN dose of 30 mg, and ibuprofen 400 plus paracetamol 500 mg TDS, pantoprazole 40 mg once daily, metoclopramide 10 mg TDS, Dalcolax 10 mg HS, and dexamethasone 8 mg once daily in the morning. Next slide, please. So the main concern is psychiatric comorbidity. The patient is depressed very often. He's because he's young and he has a lot of dreams. He's stepping into his adulthood, and because of his parents' old age and all, he's anxious and he often have panic attacks. He feel like he's dying and he won't be able to recover fully, and his parents had to witness all these episodes helplessly. And his mother has another concern because her son has taken the medicine 3 times, excessively for the last day because of his pain. She feels like he might have, he might develop morphine addiction. And the other concern is parents are not able to make any decision regarding the various treatment because of the behavioral change in their son. He don't want to move over, carry on with his life. Next slide, please. So the summary is 18-year-old male. He's diagnosed with Ewing sarcoma with bony metastasis. Primary treatment was done with bone resection and reconstruction, and the chemotherapy was done for the secondaries. Now he presented to the pain clinic with severe pain and who is already on morphine, and along with anxiety and depression. And active pain management done by titrating the IV morphine dose till complete pain relief, and later it is converted to oral morphine. And psychotherapy done with an advice of regular visits for the therapy sessions. The patient is discharged. So the discussion points, difficult pain due to psychological component, and another is morphine addiction, then the parent support, then scope of other treatment modalities since it's only local metastasis. Because the patient is not willing to move on to the other treatment types. He just needs pain medication. So how we can help him to pass on, continue his life in a more quality. Thank you.
Shahida, okay, I mean, or Raju, who was controlling the slides, can we go back a quick review from the first slide before I hand back to Sunil? Okay. Next, please. Next. Okay. Next. Okay. Next. Possibility of morphine addiction, Shahida. Is it the mother's worry about morphine addiction, or do you think he is addicted to morphine?
Because it happened only one day.
What happened?
I mean, he has taken the medicine only PRLOs previous day only for admission. So the can be a chance. I mean, the patient, if not, if he's continuing the current regimen, he might, continue taking it whenever.
Okay, understood, Shahida. I think very important point there to be discussed, and I'll very happy to leave it to Sunil. Okay, Sunil, back to you. Sorry for interfering.
So we have a young man who has Ewing sarcoma who was treated now with bone metastasis to the sacrum and ala. So the questions that need to be discussed are difficult pain due to psychological component. So what are the how the psychological component can make a pain difficult to treat, and regarding morphine addiction, parent support and scope for treatment modalities, other treatment modalities. So I would like to ask the participants regarding the impact of psychological component on making a pain difficult. Anybody can answer. Yeah, what is the impact of psychological factors on pain and making it difficult to treat pain? Okay, Dr. Abhilash, poor compliance to the treatment. Decreases the pain threshold. Okay. Perceived pain may increase. Yeah, same thing. Yeah.
Dr. Sunil, can you repeat the question? Your voice was breaking, sir.
What is the impact of psychological factors on pain and making it difficult to treat pain? The first question in the discussion point. I hope you can see the screen. Okay, so there is another question. The pain is only 5 days, so can it be a psychological? Can it be psychological?
Yes, can be.
Anybody else want to comment on this?
Yes,
Yeah.
yes, Dr. Sunil.
Yes.
Yes,
Yes.
a lot of psychological factor interplay during this process. One will the individual per se is psychological aspect to be looked into, and secondly, the family members and the social support and interpersonal relationship between the family members and the patient. These do play a role in management of the patient per se, and especially in case of these kind of patient and the pain management.
Okay.
We have to look into this each aspect before we decide our modality to move forward. Thank you, sir.
Okay. Thank you, Dr. Sandeep. Sir, what do you think about this patient's psychological problems making this pain difficult to treat?
Like for this particular patient, as doctor has mentioned, the mother was worried about the son getting addicted to morphine. So would it be, I would like to inquire from the mother how the frequency and the proper dose has been given or not. That will be first thing. Because if it's not properly given, obviously breakthrough pains and we are treating the pain at a lower threshold level. And obviously young age, boy, and other factors need to be talked about before we do it. So it will be difficult. But gradually with all teamwork, it will work on.
Okay. Thank you. Rajagopal sir, please uh, what are the psychological problems in this patient that making this pain difficult to treat?
Sorry. Can you, Raju, can you stop sharing the screen so that we all can see one another? Yeah, thank you. Sunil, I really think Shahida should be answering the question because I don't know what all it is, but there is something that struck me. Here is a man really concerned about the parents. They will have known. It's a concern that he has. But he is confined to his room. He's not spending all his time with them, are they? Is he a lonely person? He doesn't, is not likely to be socializing, going out. And so here is a person who has intense loneliness and who doesn't have anybody to feel a friend. Shahida, my immediate thought was, this boy needs a friend. And you could well be that friend.
Sure, sir.
In the sense, not being judgmental, sitting down with him, and maybe starting by saying, I know this cannot be an easy time for you. You must be going through a lot. I'm here to help in any way I can. Listen, I know that you have pain. But apart from pain, what are the major problems that you have? And he may not answer immediately. And you may have to remind him, honestly, I don't know what his name is, Mr. So-and-so. I really think you need a friend. And I think I can be a friend. Would you like to share what you feel? I promise to keep it confidential. Now, one thing that I would like to find out is, as often happens, everybody is full of advices. the family will be putting in a lot of restrictions to keep him safe. Safe is not what he wants to be. He wants some fun in his life. He may want to do this, that. He may want to go for a movie. I would say, let us take him for a movie. He may not be able to sit through it all. After 15 minutes, he will say, let's go home. That's fine. Now, very often, I don't know how many of you have read uh, Being Mortal by Atul Gawande, where he talks about elder care homes, where they are not allowed to be themselves. This boy would have a personality. There must be things that he wants to do. No, he has limited time left. He should be able to do what he really needs to do. That's so important. Somebody who understands him and acts as a go-between between the parents. The parents not all the time trying to control them, but finding out which of his desires can be fulfilled. If he does want to go and have not so healthy food at a fast food joint, well, why not? Why not McDonald's that evening? By all means, it doesn't matter. Those are the important things. I think you need to find out what are the most important things that he wants to do. Once you have got his trust, he will tell you. So long as you are not going ahead with your quick trigger and advices, hold the advices, be his friend.
Yes, sir.
I'm sorry, were you about to say something, Shahida? The boy has to be understood, his feelings, his passions, and maybe there are a few things that can be sorted out. Listen, some people have lots of fears. Am I going to hell? What's hell like? All these questions can be very real to these people. So that's one thing. I was a bit worried to hear about the addiction part. So you feared addiction because he took on rescue dose of morphine?
No, so the mother is concerned. So she's asking if this current regimen of medication is continued, whether there is a chance of morphine addiction, because he's a young boy and it's age, So
Shahida, what's your own reaction to that, if I may ask you? Are you worried about giving him morphine because of addiction?
No, that's why it's the prescription 30 mg we are giving him, and we will continuously monitor his pain and his psychological factors, how he is progressing, how often he comes out and talks with his family, takes part in the social aspect.
What will you tell him? What will you tell the mother who is worried?
Just let him be, and we will see to check the medication, how long he is taking, and the different timings to note down the timings of medication, how often he is taking, and take a note, and next follow-up we will discuss about it.
Can I suggest you a different approach?
Yes, sir.
That may not reassure the mother very much. We will see. If he gets addicted at that time, we will see. That is going to make her worried. Raju, can I share a screen?
Yes, sir.
First, we have to be clear in our mind what we are talking about. All opioid dependence is not addiction. Dependence can be of two kinds, as you can see on the screen. Raju, are you getting worried about time? 5 minutes more. This is important. So important. What's called physical dependence is something that a lot of people with on morphine may have if morphine therapy is prolonged. Not a major issue in his case, where if you suddenly withdraw it without any notice, they may get withdrawal symptoms. For this, the only treatment is gradual withdrawal. Reduce by 2/3 the dose to 2/3 the dose and gradually reduce it every week. Psychological addiction, that is psychological dependence is addiction, and that is very rare with morphine. That is very, I'll classify that. That's very rare with the morphine in cancer. If you give it, you keep giving morphine to somebody with a chronic low back pain for years, there's a potential that they may get addiction if they have the right genetic predisposition. In this boy, the chance of addiction is remote. I will not say that it is zero. So what I'll tell the mother is, Mrs. So and so, I am sure that we'll be able to give him enough morphine without addiction. With oral morphine, the chance of addiction is very remote, and those remote possibilities we can easily overcome by the way we are giving it. He needs the morphine. There will be no serious consequences. I am sure that he can have an extra dose of morphine. It's very important that he should be as free of pain as possible. I think we shouldn't be sounding doubtful. Very firmly, you will have to tell him that this is safe. And it's important that the boy should have as much of morphine as he really needs for pain. So if he expresses craving, I want some more, I want some more, that's more likely to be because of pseudo addiction, because he is in pain. But if he defies all restrictions and takes unsanctioned doses, loss of other interests, report of thefts to form of, those things are very uncommon. Sunil, you must have seen at least some 10,000 people with cancer pain use morphine. How many cases of addiction have you seen in cancer pain?
I haven't seen anyone. We had one patient where we thought might be addiction, but that was not an addiction. But physical withdrawal or physical dependence is common.
Okay, I thought Shahida may believe you more than I because you are classmates. Anyway.
Yes, sir.
Okay. So, Shahira, what were you asking about parent support?
Yeah, because the parents are also quite depressed with the son
Yeah.
going through, the
Yeah.
different
Because
episodes of panic attacks. So the parents cannot help don't know how to deal with those situations. So how they can be.
Yeah. This young man is depressed as well as he is having panic attacks and also in severe pain. So they don't know how to manage him at the home and they don't know the way forward. So,
Yeah.
I don't think we have much time to discuss. So I would like to get your input. What would you tell to his parents?
I think, so Shahida, some of you need to spend time with the parents. It's very important. Give them time, listen to them, find out. I mean, it's so much easier for the boy to come into acceptance than the parents. Have you heard that quote from Abraham Lincoln? You have not known grief till you have stood at the funeral of your own child. That's one of the hardest things for a parent to bear. So it's not easy. They need more support, even sometimes I think, than the boy, but that's not correct. They need a lot of support. So I think they need to be listened to. And at some point, they should understand that unless they are in acceptance, the most important thing they must understand is to keep the boy as happy as possible for the remainder of his life, which they will be able to do only if they are listened to, they are allowed to talk, and if they are in acceptance about the incurability of the cancer. His friends can be involved, Savera says. Absolutely. If he would like to see his friends, his parents may be worried, but that is so important.
So the last question was scope of other modalities of treatment for metastasis.
Are you asking me?
Yeah, or any other oncologist
No,
in this group?
no, I don't know. I don't know what would be the relevance of radiation. Certainly, this being Singapore, I'm sure he would have had a lot of consultations. Radiotherapists must have seen him. The possibility of radiation must have been considered. For bone pain, other measures are there, but I would encourage you to look up that 2019 guidelines of WHO, where many other measures are discussed. Bisphosphonates may help. Specifically about bisphosphonates, there is a section in that guideline. What they try, I suppose he would already have got it maybe, but don't expect it to give excellent results in everybody. The success rate, significant success rate, maybe some reduction. Significant success rate may be as low as 30%.
Okay. So I think we exceeded our time. Uh, the important thing in this patient is to find out the patient's concerns and involve his friends and find out what are the problems and what are his wishes, and so that will help us to find out the psychological problems, what are making his pain more, and we have to reassess the pain. Both we know that he already has a bony metastasis in the sacral and hip region, so physical pain is a reality, and but at the same time we have to also find out the other factors which makes the pain uh, difficult to treat. So morphine addiction of opioids is rare, but in this patient with the extra doses, probably, and it is not addiction, and addiction occurs. Actually, addiction is a disease in patients who are genetically predisposed. So we have to reassure the parents that the chance of addiction is extremely rare in him, and we have to definitely support the parents. We have to find out their concerns also, and they require a lot of support because the younger son is now has a terminal illness, and the bony metastasis can be treated by radiotherapy or by bisphosphonates, or we have to explore more about the with the oncologist. So, thank you, sir, for being with us for today's session, and thank you, Shayara, for your excellent presentation, and happy to see you. And thank you all for your active participation. It's over to
Bye bye,
Rajesh.
everybody.
Thank you, sir. So we can see you next week with a topic on communications taken by Dr. Viju Raghavan. Thank you all.
Thank you. No, shit.